her CV, or if that's already in the chat. Please go ahead and take a look through that. There is a TED link as well, a TEDx talk that she did at CSU that is kind of a great overview of some of her work. And if we can post that in the chat, that would be a great thing to check out as well. Jaclyn, great to have you with us.
Thanks, Adam. I'm happy to be here. I'm going to go ahead and share my presentation with you all. All right, so today I'll be talking about virtual reality and brain injury assessment and treatment. Again, I work at Colorado State University. I'm in the Department of Occupational Therapy within the College of Health and Human Sciences. This research is supported by an NIH Career Development Award, which is listed below, and startup funding from the OT department. And let's see if I can get my slides to advance. There we go. Okay, so I get the question a lot of why study sports-related concussion. I did my postdoctoral fellowship in pediatric traumatic brain injury, and we were trying to work with kids across the TBI, traumatic brain injury severity spectrum, from mild to severe, and the majority of the kids were coming in with mild injuries, and these mild injuries were being sustained during recreations and sports, and that aligns with what the CDC indicates, where most traumatic brain injuries, 80% of traumatic brain injuries, are in the mild category. Sports-related concussions are mild traumatic brain injuries, and being at Colorado State University, which is a Division I institute, I have a multitude of NCAA athletes to work with to evaluate sports-related concussion, because there are a lot of contact sports where these are being sustained. Then the other question of why focus on athletes, I think there's something very important about people who play sports and what it feels like to be an injured athlete who is no longer allowed to play the sport that they care about. Now, as adults, you know, who probably participate in some sort of exercise or recreation, particularly here in Colorado, it may not seem like the thing that defines you, but you can imagine that if you are the high school quarterback, or if you are a Division I athlete, that being an athlete is a majority of your role and who you see yourself as. It's the person that you are, and it's how you define yourself. When we ask athletes with recent concussions to sit on the bench, they really lose a sense of who they are. So my goal is overall to help athletes return to sports as safely as possible. And I'll talk a little bit about why that return to play point is so important, and some of the limitations that we're seeing right now at that point when we're trying to decide if that athlete who's very determined to get back to play is ready to do so or not. As many of you are probably aware, concussion, sports-related concussion, is in the public eye quite a bit. I don't know how many of you saw the Will Smith movie, Concussion, based on Dr. Bennett Amala, or you've seen the blue tent protocols during NFL games to really try to manage some of the long-term effects of concussion. So for a long time, as we saw in the movie Concussion, the long-term effects of concussion, like chronic traumatic encephalopathy, were being completely denied and completely ignored by the NFL. And then Dr. Amala kind of brought those to light, and the blue tent protocol is one of those things that is kind of the response to that, of saying, okay, we're gonna get these athletes that have suspected concussions off the field, and that is certainly trickling down into both college and high school sports. So again, as I mentioned, and I feel like I reiterate this a lot as my public service announcement, but concussion is a traumatic brain injury. But one of the hallmarks of sports-related concussions or mild traumatic brain injuries is that if you go to the ER with a suspected traumatic brain injury and your CT or MRI scan comes back normal, that is actually one of the defining characteristics of a mild brain injury. If it comes back abnormal, where there's actually something you can see on these anatomical scans, that suggests that you have a more severe injury. That makes the evaluation of concussion really challenging, because we can't use these traditional diagnostic tests, so we're left to look at behavior. And the way that physicians, athletic trainers, neuropsychologists evaluate concussion is often in a clinical setting like I've depicted here, and with paper pencil tests or symptom evaluation checklists. And as you can imagine, there are some limitations of these evaluation methods. When you think about athletes from high school all the way up to professional athletes, what they're asked to do on the field is highly complex and it's very dynamic, and there's a lot of distractors in their environment. When they're in a sterile clinical environment, many of those things have been eliminated. And so I don't think we're effectively challenging them. I think we are insufficiently challenging in these clinical settings, and thus we're not adequately prepared to say whether or not they're ready to return to sports. Additionally, the use of symptom reports is cited as the most common used method across the board for determining when an athlete is ready to return to play. And what I spoke about before about these athletes being highly motivated to return to sports because it is what serves to define them, they often fail to report their symptoms, they underreport their symptoms, they flat out lie about what is going on with them, so they end up back in play before they're ready to do so. And we have evidence that they're back in play before they're ready to do so because they're at a significantly increased risk of re-injury when they do return to play. And these risks of re-injury include repeat traumatic brain injuries, mild traumatic brain injuries or concussion, and musculoskeletal injuries like ACL tears, sprained ankles, broken bones, etc. Oops. So one of the things that I have started working on with some collaborators is considering using virtual reality to improve evaluation and treatment of mild traumatic brain injury. I'm going to focus a little bit on treatment today. Evaluation is arguably a really good idea, but it's really tricky, and I'll get to that in just a moment. But what I think we can do is mimic the demands of sports in a virtual reality environment and really see how the athlete is doing in a virtual space where we can have those complex dynamic interactions, lots of decision making that they have to do without the risk of re-injury, which is so important. Because you might think, okay, if we're trying to determine if a soccer player is ready to return to soccer, let's just throw him on the soccer field and see how he does. But that's often where we see those re-injury rates. In the virtual reality setting, if the soccer player isn't quite ready and doesn't have the reaction time, for example, to dodge an oncoming opponent, he gets hit by that oncoming opponent who's virtual, and so we can't hurt him. So I think we can use this technology to improve what we're doing for athletes with recent concussion. The evaluation piece on an individual case-by-case basis, it might be useful, but from a research perspective, it would probably take thousands of participants getting data from healthy and both concussed athletes and really being able to define definitively these quartiles of, yes, you're ready to return to play, maybe you're ready to return to play, and you're definitely not ready to return to play. And because mild traumatic brain injury is such a subtle injury, those quartiles would be very difficult to define, again, without a lot of data informing what normal performance is and what injured performance looks like. As a treatment option, however, I think it has a lot more utility, particularly right now. I think we can use these VR spaces to look at an athlete who has some residual deficits from concussion, run them through a VR protocol, and then see if those residual deficits are gone. Even on an N of 1 or a single person basis, we could see if the VR is working. It may not mean that the VR treatment protocol is optimal for every single athlete, but it would give us another tool in our toolbox for better treating athletes who've had recent concussion. Now, of course, there's some limitations and challenges with using virtual reality. I have learned very quickly that as an occupational therapist and a neuroscientist, I do not have the time or expertise to develop these VR environments myself. I partner with computer scientists and computer scientist students, and they spend, I think, an entire year developing one platform for one sport. So it's not like I can just say, oh, I've got a basketball player. Can somebody code up a basketball environment for me really quickly? We have to systematically develop these, and it takes a lot of time and doing and redoing. One of the other things is there is still questionable overlap with how well this VR system trains skills that are actually comparable to what the athletes do on the field. So for example, if they're kicking a ball in a virtual space, does it mirror the ankle and foot dynamics that they use when they kick a ball in real space? Now, I have some ideas of how to address that using portable accelerometers on the ankles in the virtual space and the real space, and then looking at the kinematics and see how well they overlap. But right now, we don't have that answer. And then finally, we know that simulator sickness is an issue that can occur with virtual reality. So users' discomfort of dizziness or nausea can occur, and particularly in mild traumatic brain injury, where dizziness and nausea are certainly symptoms that are accompanied with the acute phases of injury. And I am studying athletes at that return to play time point where they are supposed to be asymptomatic. So if the VR elicits a lot of symptoms, that might be telling in and of itself. But even so, we might have a small percentage of people who are fully recovered, as well as we can tell that right now, from their concussion, but then we can't use VR to train any of their abilities or to test that because it elicits some discomfort. So currently our project, as I started to allude to, is in a development/testing phase. We developed we have a football environment and we have a soccer environment, and the soccer environment is much more in alignment with the current science behind how you should be evaluating athletes. We got everything ready to go, ready to test, and then COVID hit. So we haven't had the opportunity to test this with athletes. The questions that we want to ask athletes are, does it elicit discomfort? Does it feel challenging enough? And does it actually feel like soccer? Because we certainly don't want this to be contrived. And so we've got a working protocol. We are hoping to be able to test that protocol and get some data and then revise the protocol. And we're working on getting some grant funding to do that, because that takes time and effort from students and faculty in order to do that. Plus we like to pay and incentivize our participants for coming in and helping us out with this development. So the future research directions that I see here is one, which is kind of, and you're not supposed to be able to see this tiny little picture, it's just for illustration purposes, is that in addition to treating brain injury deficits with virtual reality, I want to define the neural underpinnings of that. That is actually my primary focus of research. I'm funded by a career development award that allows me to use 2 different neuroimaging modalities to look at time-specific brain activity through EEG. This is an image of an ERP, an event-related potential. It's something you get from EEG data. And also using functional near-infrared spectroscopy, where I look at blood flow changes. That gives me a little more spatial specificity, or tells me where in the brain some of these things are happening. So I get a metric of when, and I get a metric of where. So that's one of the big picture things that I'm working on. I'm also looking to test VR treatment potential on brain and behavior. So using some of these data that I've collected with my career development award, I'm able to say, okay, this is what the brain looks like before we try any sort of intervention. And then we can say, this is what the brain looks like after they do a VR treatment protocol. We can also measure behavior and see if things are getting better for these athletes. That foundation grant is due on August 1st. And then finally, I would like to be able to do simultaneous neuroimaging and virtual reality. And I'm working with some colleagues to try to develop an integrated fNIRS. That's that functional near infrared spectroscopy. That's the picture on the right with the girl wearing the head cap and the backpack. And that's the one that tells me where in the brain things are happening. And as you can see, to the left of that is the Oculus Rift. And you can tell on the Oculus Rift that there's a strap that goes over the head. So as you can see right now, those 2 pieces would interfere. It's not a big deal to try to stretch that strap, but we would want to make sure that these 2 things could integrate really nicely. And ideally, I would like for the participants to also be able to see the brain activity that I'm able to see while it's happening. I think that would be a really interesting way to move forward with virtual reality and fNIRS, is integrating those 2 systems. Because as you can see in the picture on the right with again, the woman wearing the backpack and the head cap, that is a completely portable system, and Oculus Rift and many of these other VR technologies are either becoming completely portable, or they're tethered by a very long cord so people can move around in a space. So I think there's definite potential for those to be integrated. And I'm working on a foundation grant for that, which is due July 28th. So I'm quite busy right now. So that's all I have to share with you right now. I just kind of want to give you a big overview of the work that I'm doing, the potential that I see for virtual reality for right now mild traumatic brain injury, but certainly if we can use VR to treat mild traumatic brain injury, it has a lot of potential for more severe forms of traumatic brain injury or other neurological conditions like stroke, or even progressive neurological diseases like Alzheimer's, Parkinson's disease, multiple sclerosis. So I see a lot of potential for this technology in allowing us to elicit the types of demands that people are experiencing in the real world without them actually at risk for any sort of injury or negative consequence from doing that in the real world. So with that, I would like to thank my SCORE lab. That's not all of them. SCORE stands for Sports, Concussion, and Occupational Rehabilitation. We did a bicycle brewery tour as a lab last October when we could all go out to restaurants without masks on. I'm sure you remember that. So that's part of my lab team. And then my research collaborators and mentors, Dr. Francisco Ortega from Computer Science, Dr. Brian Tracy from Health and Human Sciences, and Dr. Patty Davies, who is my faculty mentor in occupational therapy. And at this time, I will take your questions.
Yeah, thank you, Jaclyn. Yeah, great presentation. Just take a breath as we dive into the questions here. So one from Matthew. To what extent do you feel as though the cultures inherent within contact sports promotes an irreverent attitude toward injury, and sports-related concussion particularly, as an injury which is often invisible to the naked eye? Aren't we always working against these deeply rooted attitudes that athletes in competitive team sports will always adopt?
Possibly. I certainly don't want to ignore the fact that that culture is there. I do feel, however, that with the NFL having to acknowledge the issues of chronic traumatic encephalopathy that has been directly linked to repeated head exposure in professional football players, I think that that awareness is trickling down. We are seeing huge decreases in youth football. I think in 2015, I might have the year wrong, we saw youth football cut down by about 50% enrollment in youth football because of all of these issues. We're seeing across the board that there are, in most contact sports, you know, in basketball, you've got your flagrant 1, flagrant 2 fouls because of head contact. You're seeing a lot more emphasis on preventing head injury. I think that you're certainly still going to have coaches and parents and kids who don't care and are still going to think of it as a, excuse me, getting your bell rung. But I think overall the culture is shifting to a little more safety and a little more awareness, and some of those long-term considerations of, okay, my kid got to go back into this football game when he wanted to, but is that going to impact his ability to get into college because he has memory impairments from getting hit in the head so much? I think a lot of parents are starting to think that way.
Yeah, I imagine that's got to be a big cultural shift from, you know, American identity of football and the hard contact. And I certainly remember playing football in school, and, you know, yeah, having that. Yeah, just shake it off. And the only time I was told to sit on the sideline is when I was actually throwing up from a concussion. Pretty much anything else was, well, can you walk straight? Can you run? Okay, you can get back in there.
And
It seems
Adam,
like,
if I can, sorry, go ahead.
No, go ahead.
I was going to say, if I can say something else, particularly with youth sports, states have laws in place to prevent something called second impact syndrome. So here in Colorado, we have the Jake Snakenberg law, because we know that if youth athletes particularly get a concussion and then they get hit within a short time frame after that, so they get put back in the game because they are, for example, not throwing up on the sidelines, they're at risk for this second impact syndrome, which can cause permanent disability and death. And Jake Snakenberg was actually someone who passed away from a repeated head injury shortly after his first concussion because he got put back into the game too soon. So there are laws that prevent any sort of cultural attitudes of you could shake it off. Well, there's now legislation to prevent kids from getting severely injured or killed from those kinds of attitudes.
Yeah, that's relieving. I don't know if there was any of those such laws in place back when I was playing football, but I can certainly see the need for those. I have a question from Rosemary. How do you foresee that VR technology could be used for Alzheimer's or for those who are older than most of the athletes who could benefit from VR treatments?
Sure. I think that's a great question. So I worked in a rehab setting for about 5 years. And one of the things that we were limited in was really being able to test if our patients were ready to return to home or ready to return to real world activities. Taking something as simple as crossing a street, that's a really high risk issue to try to execute in a hospital setting. So the hospital I worked at was right next to a larger hospital. We could cross the street and go to the Starbucks that was inside the hospital. But we had to know for sure that our clients, particularly clients with cognitive issues like adults with dementia, were ready to do that. I perceive virtual reality as something that you could put on this client and ask them to cross the street in a virtual space and see how well they do, see how well they look both ways for traffic, see if they're waiting for the cross light, see if they're, they're attentive to their surroundings and making good decisions. You can also see if somebody just gets completely frozen and refuses to cross the street altogether because they just don't know how to time that behavior. I foresee this for using with a variety of people. Like if someone has had a stroke and they aren't seeing the left side of their world very well, something called left neglect, we could use this to see how well they're perceiving a virtual environment. You could use this to practice cooking with more and more complex cooking tasks to make sure that someone wouldn't be likely to start a fire in their own home. I really think that some of the things that we're limited to doing in the hospital setting because of the equipment and the space, we could overcome with virtual reality environments.
To what extent do those kind of analyses rely on an observer or a rater to be able to make those decisions about is this person appropriate, and are there ways that some of those analysis could be more automated?
Right now, so there's kind of a two-part answer. There are currently many things that are ongoing that help clinicians extract and understand the data that are coming from VR systems, so that those are much more automated. But the other part of it is, clinicians are consistently using their clinical reasoning skills to say, is this patient safe or not, without any kind of measurement of saying, okay, they fell on this side of the curve, right? I would consistently have to give reports on whether or not I thought a client was ready to go home and get on and off the toilet safely by themselves, without ever seeing them do that on their own in their own home. For these street crossing, the street crossing example, if a client gets hit by a car in a virtual space, all right, maybe the first one is just they don't understand the system, but if it's happening over and over and over again, that gives you some pretty good insight into their behavioral performance. So depending on what the task is, and with some reasonable expectation that it's going to take an older adult a little time just to figure out the system. But if they've figured out the system and they're still failing to meet some of those basic criteria, and you can see other adults meeting those basic criteria that you put the headset on, I think that gives you some good insight into their safety and their ability.
Yeah, thanks. Question from Hal. Have you used biofeedback or neurofeedback in the VR environment?
Not yet. That integration of the fMRIs and the VR, I think would be a really cool way to start that biofeedback. I mean, I'm a neuroscientist, so I don't really know if I'm abnormal in what I'm about to say, but I think it would be super cool to be able to see my brain activity when I was doing a driving simulation, or if I was navigating a new space in VR and it was just popping up my brain activity. I'm like, oh, look at how well my right cortex, the right side of my brain is working. You know, I think that would be really, really helpful to be able to see those things. And whether or not that's biofeedback, it might be like a kind of long-term biofeedback where I'm able to see that, oh, okay, I'm learning a new task and I see lots of brain activity. And then as I practice that task, I see less and less and less brain activity, or an increase in neural efficiency. I think that that would be really informative for people who had basic understanding of brain anatomy and physiology, and certainly for those of us who work in neuro populations, of saying, oh, this person has had a stroke on their left hemisphere and their left hemisphere has been lagging behind their right hemisphere in its activations, but every time we do this therapeutic activity, I'm seeing activation of that side of the brain. How amazing is that, that I know that the treatment I'm using is doing what it's intended to do.
Can I make a comment here? Can you hear me?
Sure. Yes, I can hear you. I'm sorry, who's speaking?
I'll show my video. Okay, so yeah, I'm the founder of Thought Technology. We're the largest biofeedback, neurofeedback company in the world. We've got about 70 people working for us. And we've worked a lot with VR and biofeedback. There's several companies like Sios out of Spain and Beyond VR. We're working with a company called OVA in Montreal right now.
Mm-hmm.
And it's incredibly useful. We've been doing this, using biofeedback with, on screen with normal like bar graphs and line graphs and all. But when you put it in the VR world, for something like systematic desensitization, it's incredibly powerful. For example, you feedback conductance, which is basically sweat gland activity, sympathetic nervous system activity. And you've got someone walking a plank between two 10-story buildings. It's amazing. People end up on the floor doing that, but you can also see a huge increase in the heart rate and decrease in heart rate variability and skin conductance and everything else. So yeah, I could see how it could be very useful as well in training people with Alzheimer's or other disabilities and concussions, because you can keep track of your respiration, your skin conductance, heart rate, muscle tension, and brainwave activity to perform at your peak. There's a lot of work being done with sports. We've worked with AC Milan and Chelsea and Vancouver Canucks, etc. And they've used a combination of biofeedback and neurofeedback, and they've gotten amazing responses. And VR is something we think is really important. That's me.
Great. Can I ask you a follow-up question, please?
Sure.
So the biofeedback you're talking about is your heart rate, respiration, skin conductance, so basically like sweat responses and things like that. Do you have EEG or fMRIs pulled in to the VR space?
Yes. Yeah, as a matter of fact, I don't know if you have Alex Bilodeau and Jen Heil, they won the freestyle skiing at the Olympics the last time. They both trained with Penny Wertner from University of Ottawa on neurofeedback using alpha and SMR feedback. So
okay.
what he would do is when he's going down the hill, he would be in the SMR state, which is really, really focused. And then he'd go into the alpha state when he does his flips in the air. And then he switched back, and he spent months training to do that. And both of them did, and they both got gold from doing that. So yes, we use a lot in sports, a lot of neurofeedback. But you can contact me offline if you're interested, and I give you some references and all.
Yeah, that would be great. Thank you.
Sure.
Yeah, thanks. That's fascinating. I know personally I've seen huge benefits of neurofeedback in my life, and I'm just happy to see it being shown more widely. Another question from Julian. How do you measure the near and far transfer of your VR training not only to the specific cognitive domain, but to real life?
That's a great question. So what, did you say near and far transfer?
Yes.
Near and far transfer?
Yep.
So right now we have a strategy for looking at near transfer. So the grant that is going in on August 1st is designed to look at near transfer. So we have a baseline task that has essentially two versions. So there's the baseline test that they would do prior to any VR training. That baseline test is a movement-based test that can be done with simultaneous fMRIs. So I can look at their behavioral performance. The baseline task is it's called the dual task screen. It uses single tasks, dual tasks, and compares the performance differences when someone is single tasking versus dual tasking. And then the VR training protocol has elements of single, dual, and triple tasking, but these do not overlap at all with the tasks that we use for baseline. So we're not teaching to the task in this VR space. And then at follow-up, they do the second version of the dual task screen with simultaneous neuroimaging. So we can see from a behavioral standpoint if we're seeing improved performance on what we're calling multitasking or dual tasking, where we would essentially expect to see a smaller dual task cost, where so if on the dual performance, the dual task performance is significantly lower than the single task performance, we would expect those to be closer in performance after the VR training, where multitasking or dual tasking performance looks like you're just doing one task at a time. And we're also evaluating for neural efficiency. So as I mentioned, this is simultaneous fMRIs with this measure, and we would be looking to see that they're actually using less neural activity at follow-up than at baseline, particularly because we're seeing a heightened degree of neural activity in our concussion population after they get injured and at the point that they're returned to play. So these are athletes, all of them, who have been cleared by their physician to return to play, and we're still able to see some neural inefficiency and some behavioral deficits with our measures. As far as looking for far transfer, which I think was the other part of your question, eventually we are going to look and see how well this training, if it works for the near transfer, then we'll see how well that training protocol is improving on-field performance. And we'll have to figure out exactly what metrics we want to use for that. But I think we need to establish that we can elicit near transfer before we look for far transfer. Did that answer the question?
So I'm unmuting because I was the person asking this question. And thank you very much. Yes, it did. But there is one more question I have concerning this near transfer. And this is, do you use standardized psychological testings when you do these near transfer tests, or do you use a specific test that is about the scenarios that you develop in VR?
No, we do something kind of in the middle of that. So the standard psychological test that's typically used in concussion, I don't even know if you would call it a psychological test, but the impact, the computerized, I always forget what the full acronym, but the immediate post-concussion assessment, I should know this acronym and I always forget what it is, but that is the one that's computer-based, that they use baseline, preseason, and then they use it post-injury. We have those data, they're not terribly useful. We don't see a lot of deficits on those. We know that they lose, that measure loses its sensitivity. Many measures that we have lose their sensitivity to concussion after the first couple weeks. And again, we're evaluating these participants at return to play. So what we have started doing is using the dual task literature, is we created a dual task screen that's much faster to administer, and our instruments are quite portable and low cost. That's the measure that we're using. And again, there's some overlap, which makes it a near transfer task rather than a far transfer task with the training tasks in VRs, but they are not the same.
Okay, thank you very much.
Yes, thank you for that question.
Yeah, thank you, Jaclyn. Question we have from Don. We've heard on previous calls about portable EEG headsets. Wondering your senses of the state of the art of mobile fNIR.
So that's what I'm using, which is why I was a little surprised, and maybe I misunderstood that fNIR is being used with simultaneous VR, because I haven't quite seen that. But yeah, I think the system that I'm using, to my knowledge, has the best head coverage for a mobile system. So I have 16 sensors, or I have 16, I'm sorry, I have 16 emitters and 16 detectors, which with my setup, I've got about 42 channels of head coverage. I'm able to cover, and this was by design, the bilateral motor cortices, and then the right lateralized prefrontal cortex and posterior parietal cortex, because I think those are parts, or they are parts of a frontal parietal attention network. So I'm able to kind of look at attention mechanisms and motor. So the company that I work with is called NearX, and the device that I'm using is called a Near Sport 2. There are certainly other mobile fNIR systems, but I haven't seen them with quite as much head coverage. Most of the time with your mobile systems, you get head coverage across the front of the head. And so I probably should have been a bit more specific with this integration of having as much brain coverage as possible, not just the frontal strip, and being able to integrate that easily with VR technology.
Thanks. Can you comment on the possibility for movement artifacts in fNIRs versus EEG?
Yeah, so with EEG, you have motion artifacts in EEG are much more problematic because of the time specificity that you've got. With fNIRs, because you're working with a hemodynamic response and you've got that 6-second delay, you don't really have to, the motion artifacts are much more easily managed. I feel like so I do both EEG and fNIRs research, and the movement artifacts in EEG can certainly be filtered out, but you're often doing artifact rejection. If a participant, for example, sneezes, you would often drop that segment of data. With the fNIR system that I have, I'm able to eliminate motion artifacts from the participant doing jumping jacks, walking, running, doing push-ups. The system is designed to eliminate all of those without losing any signal. Or losing, I shouldn't say losing any signal, because that's probably a little bit too extreme, but without losing any meaningful signal.
Is that still somebody going through and manually choosing what parts of the data they're going to keep, or is some of that automated by your software?
It's automated by our first level processing system. So it is regressed out of the raw data.
Nice. So we've got just a few minutes here, but still time for another couple questions if there are any more.
Hello. Hey, this is Don. I'm not sure how to exactly ask this, but for concussion protocols on the field real time, athletes have a baseline that's been measured.
Mm-hmm.
In terms of metrics, is there more work going on in refining those baselines, or is that pretty well understood?
The problem with the baseline testing is that the athletes have figured them out often, and they will sandbag them. So one of the biggest issues with the impact that I mentioned earlier is that there's a known sandbagging effect. The athletes are taking these tests that they have to do preseason and doing as poorly as possible, and then when they've gotten a concussion, they actually perform better, so that they're basically useless. There's certainly some more work going into improving baseline testing. One of the strategies that my team and I have proposed is telling the athlete you're measuring one thing and measuring something else. So we found success by, for example, we'll tell the athlete we want them to tap their fingers as quickly as possible, and we'll tell them we're counting the number of repetitions. But what we're actually looking at is to see if there's any mirroring on the other side, because that suggests that there's some some things that are going, there's a lack of inhibition, a lack of neural inhibition that should be in play. So we don't tell them that we're looking for this. This is not trying to deceive them, or, you know, it's not meant to be cruel. It's meant for us to get a better metric of how they're actually doing. So when we do these kinds of things, the athletes go as quickly as they can, but we look for things like, okay, how many times are they tapping? That's certainly one of our metrics, that mirror effect. And we're also looking at like dysrhythmic movements. So that gives us a little bit more information about how well their brain is behaving after an injury.
Great. Thank you.
Mm-hmm.
Okay, Adam, I think we're at the top of the hour. So any last thoughts from you?
Thanks, Jaclyn. This was really fascinating. I know there's quite a bit more that we could go into, and you know, different details and tangents here. But I appreciate your presentation and answering the questions, and we're definitely happy to have you.
Yeah, my pleasure. Thank you for inviting me. This is great. And my email's down at the bottom of this slide for anyone who needs or has extra questions or would like to reach out. I'd love to hear from you.
Appreciate that. And we put that in the chat window as well.
Great.
And Jaclyn, just listening to this, I've got a placeholder to ask you back, because it would be cool to see that, you know, once the VR project gets going, you know, early results or whatever. But
absolutely. We just have to cure COVID first, and then we'll be back up and running.
Indeed. All right. Well, so apologies again for the problems with the link, and thank you everybody who struggled to get here. Great questions from the audience. We appreciate your participation. And we'll see some of you, I hope, next week. Thank you.
Thank you.